There we go. All right. Hey, everybody. Good morning. I know some of you are still kind of connecting to audio and everything. I'll just give a brief introduction. My name is Lindsay Troxler. I am with the Louisiana Quality Network. I am a project manager. I've been with them since July, so coming up on a year. Today, thank you all for joining us with our first opioid grand rounds of 2024. Today, we're going to focus on the efforts of the ED inpatient clinical pathway. And we are so lucky to have Dr. Bridget Egan from LSU Emergency Medicine with us today. And she's going to be talking about not just naloxone, novel approaches to opioid use disorder in the emergency department. So if any of you were with us during the milestone development of the development phase of this opioid metric, you're going to remember Dr. Egan presenting her expertise to us during one of our metric development workgroup meetings. We're happy to have her here today to talk about the current work she's undertaking and how it can possibly be replicated in other facilities. So we're going to ask today that you guys remain on mute during the presentation, hold your questions or comments till the end of the presentation. You can certainly type in the chat and we'll get to those at the end. And once her presentation is complete, then, if you have questions or comments, you can unmute and ask those then. Our recording and slides from today are going to be uploaded to the Confluence site in our opioid subcommittee folder. If anyone is in the room with you and their name is not showing on the screen, send us their name and their hospital affiliation in the chat so we can go ahead and give them credit for attendance. And then right before we get started, so our next grand round will be held on August 21st at 11, and that one is going to cover our mother-baby clinical pathway. So if you don't have it on your calendar, email Brandy or I, and we'll get that sent out to you guys. And then our final grand round is also being planned for November 6th. So thank you all again for joining, and I'm going to turn it over to Dr. Egan.
Hi, everyone. Good morning. Thank you for joining us this morning. So I am going to be talking about the scope of opioid use disorder in Louisiana at large and sort of how that filters down to what we can do to address it in the emergency department. So just to start, I have no financial relationship with any of the products or services I'm going to talk about, though I really do support naloxone as a concept. So to start, where are we now? What does the scope of the opioid epidemic look like? So when we look at national survey data on who uses drugs and what kind of other health problems they have, we know about 3.3% of Americans over 12 either use injectable opioids or use prescription opioids outside of how they were prescribed, which we call misuse. The vast majority of people surveyed use prescription pain relievers, and then a smaller group use both pain prescription medications as well as what they call heroin, but I put an asterisk there because we know that most heroin is fentanyl at this point. And then we have a much smaller group of people that use injectable opioids only. And when we look at opioid use disorder in Louisiana, the data sort of supports that we have about similar to national averages of who is using opioids. About 18% of people have a substance use disorder of all kinds, including alcohol use disorder and other conditions. And we have 141,000 people over the age of 12 that are living with opioid use disorder. And among those people, we have one of the lowest ranking numbers in the nation for people that are seeking treatment. When we look at the economic cost of what it looks like in Louisiana, we know that opioid use disorder takes up about 2.8% of our state's GDP. 93% of this was related to overdose deaths. And that number sort of comes from the cost related to loss of productivity, emotional strain, increased spending on healthcare and social services and criminal justice and childcare and all of these other things. And what it doesn't tell us is that by spending all of the money that it costs to provide for the people in the wake of an overdose death, that we are not spending any of that money on treatment. And when we start to look at Medicaid, we know that about 40% of people living with OUD are Medicaid beneficiaries. And in 2021, which is our most recent data, Louisiana spent about $71.8 million on opioid use disorder. The vast majority of these costs were related to hospital admissions for complications from untreated opioid use disorder. And so those admissions are typically because people have, injection related infections like endocarditis, complicated overdoses, other conditions related to their use. And rather than, trying to get us away from treating these conditions, we also have to examine that we're not spending any of this Medicaid money on getting people into treatment, considering the vast majority of it is related to untreated OUD. And who is it affecting in Louisiana? We know that accidental opioid overdose is the most common cause of death in pregnancy. For our pregnant patients in Louisiana, about 34% of all deaths during pregnancy were the result of overdose during the last Louisiana pregnancy mortality review report. This is more than hemorrhage and infection and all other causes of what actually led to the deaths of pregnant people in our state, which is pretty stark and alarming. For those patients that are pregnant with opioid use disorder that goes untreated, eventually that, results in, babies being born with an opioid withdrawal. They were exposed to opioids in utero, and upon being born, they are still having that opioid dependency, which results in withdrawal when they are born. This is a preventable condition if we can get mothers into treatment early and start screening and getting them onto programs where they, can get medications for opioid use disorder, and we can sort of improve these numbers, if we make some really strong efforts across all forms of medicine into trying to reach these patients. And then we have to look at the human cost. In 2022, 1,420 people died from opioid overdose in Louisiana. And these are preventable deaths. These didn't have to happen. And looking at these numbers, they are just going up. These are the rates from 2014, and I added 2022 on here because it wasn't on this graph. This is from the Louisiana Opioid Surveillance Program. But you can see that, the things that we are doing right now are putting a small dent in things compared to 2020 to 2021, but we still have a lot of work to do to sort of improve mortality for all of these patients. And, when we talk about like, why is this happening? We know that, we've had a vast increase in fentanyl entering the drug market. It's sort of outstripping heroin as a street drug that is, widely available. And, fentanyl has a much higher potency than other opioids on the market. It's much more difficult for people to dose themselves with. And so there's a higher risk of overdose and death related to its use. And we can see in this map, this is change in deaths by specific opioids provided by the state, and fentanyl and other synthetic opioids are just going through the roof. So we're entering sort of a new phase of what drugs are out there, and we need to sort of address how we are approaching this problem related to that. So how did we get here? This is sort of where we start looking at, what are the root causes of how this problem got so bad for Louisiana? And that involves unpacking sort of the perfect storm that our state has created for people having poor outcomes related to opioid use disorder. We have traditionally always had, a lack of social services, limited mental health care options. Our patient population experiences a lot of trauma related to poverty, racism, stigma against drug use, increased criminalization of people that have medical conditions like opioid use disorder. We have mass incarceration, which contributes to a lot of poor outcomes, a lot of limited understandings of the causes that cause this, poor harm reduction resources in a lot of underserved and rural areas. And then honestly, the influx of fentanyl has only made all of this worse. So in unpacking this, the best place to start is sort of looking at who are people that use opioids, or a better way of framing it is what we think about people that use opioids relate to what is actually going on. So just to start, most people that use opioids are over the age of 25. Most people that start using them start over 25, and most people are over the age of 26. Most of our overdoses that we see in Louisiana are occurring in people from 35 to 60 years old. When it comes to gender, women have higher numbers of prescriptions for opioid pain relief. Men use more injection opioids and have higher rates of death by overdose. In our transgender and gender minority community, they have a 3-time prevalence of OUD compared to cisgender people. They have higher rates of social isolation. They're refused care by providers. They experience a lot of stigma and, social and physical abuse from other people, and tend to withdraw from treatment because they have been mistreated by the medical community, because they have experienced so much trauma related to that. When we look at sexuality, there's a similar trend there where, LGBTQA plus people experience a lot more trauma, lack of support, limited resources, discrimination, and have often, been on the receiving end of a lot of stigma from the medical community. This results in poor trust in treatment by medical personnel, and they tend not to seek treatment as often. And because of a lot of the trauma they experience, they have twice as much opioid use disorder as the general population of heterosexual people. When we look at race, in Louisiana, white people make up the largest number of people that use opioids, but that rate among Native American and Black people is much higher. And this is, again, related to a lot of trauma, a lot of poverty, systemic racism, and lack of healthcare and mental health access, can sort of contribute to these rising rates of drug use. We know that Black and Hispanic patients receive fewer appropriate opioid prescriptions for pain. They're more likely to be drug tested and have prescriptions discontinued because of a positive test when they are on medications for opioid use disorder. And they're less likely to have that treatment for opioid use disorder initiated, whether that's buprenorphine, methadone, or receiving naloxone. And you can see the results of this is that, on this, graph, and this is a national study, that the rates of deaths in Black men have skyrocketed since 2014. And this is all related to a lack of access to care on a numerous number of fronts. When it comes to income, poverty plays a huge role in, people that have opioid use disorder. 54% of people with OUD live below the poverty line. 25% of all fatal overdoses occur in people living in poverty. This is the result of increased life stressors, adverse child events, ongoing trauma, and limited access to healthcare treatment. What's interesting is that 70% of adults with substance use disorder of all kinds are employed. This goes against the, traditional thinking that people that have a substance use disorder are either unhoused or, completely living off of, government subsidies and that kind of thing, where these are in reality people that are trying to make ends meet, are trying to take care of their families while living with a serious medical condition. When it comes to mental health, about 1 in 5 Americans with mental health disorders use opioids. This is about half of all opioid prescriptions written in the US. And for people that have opioid use disorder, about 40% of them also self-report a mood disorder like depression or anxiety. We know that in Louisiana, we have pretty limited mental health care resources, especially in rural areas and sort of the more underserved parts of the state. So having a limited access to these resources also increases the rate of opioid use in these areas in Louisiana. And what you'll see in a general trend between everything I've just talked about is trauma. About almost all patients that have opioid use disorder have experienced major life trauma, whether that is racism, the loss of reproductive rights in Louisiana, adverse childhood experiences, PTSD, incarceration, sexual assault, housing insecurity. And when we start to really examine that there is a large underlying cause of why people have this, it helps us to sort of reframe how we think about opioid use disorder from what was previously something relegated to the criminal justice system, where we express that these patients are weak or, degenerates or criminals, and instead recognize that these are people with limited access to the care that they need and are trying to treat their own mental health and other problems the best way that they can, which is to self-medicate with these medications and drugs. And so how do we treat this? Really, the best way to look at it is a three-pronged approach: person-centered care, treatment, medications for opioid use disorder, MOUD, and harm reduction. And underneath each of these three tiers, I've listed some different concepts that sort of go along with them, but this is not a comprehensive list. Under person-centered care, really what that means is, the old adage that we sort of stick to, which is meeting the patients where they're at. And, the first and foremost is rejecting stigma, getting away from calling people addicts, and sort of relegating them to this one term. They're people with substance use disorder, you know, saying, like, we need to not take care of these people. They're not worth it. Rejecting these concepts and acknowledging that opioid use disorder is a treatable disease, that has both medical and psychological components. Caring for people without bias. When we start to examine that patients should be treated for opioid use disorder the same way we treat them for diabetes or for heart disease, like any other illness, it starts to move the needle away from, these people are a burden on the healthcare system, and instead that they are people that, have a condition that we can help and that they can have really good outcomes. When it comes to treatment, medication for opioid use disorder, really we want to create a system in which we have the lowest barriers for people to get on medications that can help them, primarily buprenorphine or methadone. Low barrier means that handing patients a phone number when they may not have a phone, may not have transportation to get to an appointment, may have other, psychological or social barriers to getting to places is not enough. Where we need to either bring these medications to people or bring people to these medications to make sure that they are able to get access that they need. Part of this means, treating patients when they're admitted to the hospital, when they're in withdrawal. We know that people leave AMA at much higher rates from admissions when they have OUD and they're not treated for their underlying, withdrawal symptoms. Patient that has a broken leg admitted to, orthopedics still needs treatment for their opioid withdrawal. And by not doing that, we are just increasing their, complications and their morbidity and mortality from their other conditions when they're admitted to the hospital. And one of the biggest places that, we have seen, our state do a very poor job is treating people when they're incarcerated. People enter our jail and prison systems with OUD and often have no access to any kind of treatment related to receiving buprenorphine, receiving any kind of other medications that can help them. And again, this just sort of adds on to the burden of stigma toward people that have opioid use disorder and results in their poor outcomes. And then finally, harm reduction. The top of the pyramid here is distributing naloxone, a medication that can reverse overdoses when they happen, and can lead to like vast decreases in morbidity and mortality if we have lay people around those patients that have opioid use disorder, ready and educated on how to administer this medication. Sterile syringe access programs where we, offer people with opioid use disorder access to supplies to use these drugs safely, that can prevent, injection related infections, things like endocarditis or deep tissue infections, and also hepatitis and HIV. And then access to social services. We know that many of these patients have a hard time navigating our systems, in a way that many of our patients without OUD have a hard time navigating our system. So being able to provide them with access points to, help get them into housing, help get them into treatment, help get them to their appointment, go a long way in sort of bolstering, sort of a holistic process of getting people where they need to be on treatment. And altogether, all of these different ideas create a culture in medicine of empathy and non-discrimination, and treating this like a medical and psychosocial condition that it is, instead of a like criminal burden problem on our system. When patients recognize that, which they will when they're treated well, they, feel safe. They feel like we are people they can come to for help. They feel respected. And then causes them to seek out treatment and seek out access to getting into care, which is what we want. So what does the treatment landscape look like for 141,000 people with OUD in Louisiana. So about 22% of people over 12 in Louisiana were classified by SAMHSA as needing treatment for substance use disorder between 2021 and 2022. And about 75% of those people did not receive treatment. And so this is a huge problem. When you look at substance use disorder treatment facilities in Louisiana, we have 111 of them that will treat OUD. 82% of those accept Medicaid. 87 of them offer medications for opioid use disorder, and only 12 of them actually offer services in Spanish. When it comes to finding a provider that can prescribe medications for opioid use disorder, previously, up until about 2 years ago, everyone had to have an X waiver that was, a special certification provided by the DEA in order to prescribe buprenorphine. This has been discontinued, where anybody with a full DEA license can prescribe this medicine. However, not everybody is willing to prescribe it, either because they don't know how, there's a lack of education there, or because there's some underlying stigma about treating people with OUD, about what your patient base will look like when people find out that you're a doctor that does this. So there are still remains a lot of barriers to getting people to actually starting these medications. When it comes to trying to find a provider that provides MOUD, it can be really difficult. Unless someone is referred to someone specifically, if a patient goes to seek care on their own, they're often routed in Louisiana to the Louisiana Department of Health and SAMHSA websites to find the care they need. And so I did a deep dive myself as if I was a patient trying to find a provider through these websites. And going through SAMHSA, it listed 612 providers in Louisiana, and LDH said there was 36 treatment providers for OUD. Both of these lists were lacking a lot of people that actually also prescribe these medications, but patients wouldn't be able to easily find them. We know that new people are starting to prescribe buprenorphine every day, but unless a patient knows how to locate those people, it can be really, really difficult to find that. And that's, not to mention the barrier of, I have internet access. Many of these people may have a hard time doing this. Many people may have issues with, functional literacy or even tech literacy that can make this very hard. And then treatment in incarceration. We know that patients that go into withdrawal when they're incarcerated are vulnerable to any illness they have getting worse. They have increased suicidal ideation. Because they are sick, they're at higher risk for violence and abuse committed on them by other people, and death because of their opioid use disorder. Not having access to naloxone in prison cell pods increases the time to treatment for accidental overdose, which increases morbidity and mortality in these patients. And we know that forced cessation without MOUD, where someone that has opioid use disorder enters the jail or prison, they are now cut off from that drug that they were using, their tolerance will drop. And when they are released, they're at higher risk of overdose and death because their tolerance is lower. If they are going to use again, their body is not ready for it and they can easily die. By prescribing medications for opioid use disorder, not only does it treat the symptoms of a person that is ill and put into the care of the state, which is their ethical obligation to do, but also it helps them get on a track toward taking care of this one aspect of their life that is causing them problems, and can get them into long-term treatment once they are released from jail or prison. In Louisiana, as of 2022, which again, this is a little bit dated and these numbers may have been improved, there are only 3 listed jails and prisons that are offering treatment. So this is a huge problem and a huge place for improvement in our state overall. So where do patients end up when they don't have access to treatment? The emergency department. And so this is where I come in. Between 2016 and 2017, opioid-related medical complaints accounted for about 1 in 80 visits to the U.S. emergency departments. Overdoses made up about 27% of these visits, with complications from OUD making up the other 72%. So most of what we're seeing in the ED is not just overdose, but also people with complications related to untreated OUD. And this results in about $5 billion in annual ED charges. And you can see from this graph, the numbers of patient visits for, OUD in general is just going up and up and up across, metro, large central, and like rural hospitals across the board. And so this is an ED problem, and the emergency department does have a role to play in addressing it. And when we look at Louisiana, this is numbers from Louisiana Department of Health for opioid overdose. There were 6,400 visits to ED departments for overdose in 2021, and those numbers are just going up. Parishes with the highest related visits for opioids were Orleans Parish, Jefferson, St. Tammany, Livingston, and East Baton Rouge, which I know several of the people joining us today are working on projects in each of these parishes. And so this is very pertinent to sort of what we're trying to address. We know that when patients survive an accidental opioid overdose and they make it to the ED, they're 100 times more likely to die by drug overdose in the following year. They're 18 more times more likely to die by suicide compared to the general population. And their 1-year mortality following an ED visit is about 5%. And so this is huge when we examine, there is a period of time where we have someone in our care that we can talk to, that we can make plans for, that we can help transition into treatment that is very high risk of dying within 1 year. And so the ED's role in trying to address this while we have them with us can make a huge difference in sort of addressing these poor outcomes. And so whether people are experiencing an overdose or they just want help to try to improve their opioid use, the ED presents a place that offers 24/7 access to trying to connect them to treatment. And that's really how we should address it. So how does the three-prong approach work in the emergency department? Person-centered care. Again, we want to try to, expel stigma toward people with OUD from our medical practice. But really, one of the biggest things we can do is link patients to care when they leave the ED through a warm handoff with community providers, as in we start the process and we get the patient to the next step of continuing treatment. Offering treatment in the ED, medications for opioid use disorder, ED buprenorphine initiation for withdrawal, or if after an overdose and before entering incarceration are things that we can do to sort of improve these outcomes. And then harm reduction, naloxone distribution from the ED after an overdose is huge. Just talking to patients about where to get sterile syringe access, talking about what options are available to them if they, are using in a way that is unsafe. Is there a safer way for them to use drugs? All of these together sort of improve outcomes in mortality. They result in decreased return visits and increased access. So I'm sort of gonna go